Hello, everybody, and welcome to CE Elevated. This is a CSU Vet CE webinar series. I'm your host, Dr. Ross Palmer from Colorado State University, and I'd like to thank you for joining us on behalf of CSU Vet CE here at the Translational Medicine Institute. We've aptly named this webinar series CE Elevated, and that's symbolic of our Colorado mountainous terrain, as well as our mission to provide you with an elevated CE experience in all that we do. We do believe there's a great power in the collision between inspired learners, engaged educators, and meaningful experiences. Tonight, we're sincerely thankful for the support of Karl Storrs Veterinary Endoscopy, as well as Animal Reproduction Systems, ARS, who have made this webinar episode possible. Tonight, I've got a special guest for you, Dr. Greg Burns. Dr. Greg Burns received his DVM from Colorado State University and is a board-certified theriogenologist. As you know, that's a reproductive specialist. And he has been a lecturer in small animal theriogenology here at CSU since 2006, and he's currently an assistant professor of theriogenology in the small animal reproduction service at Colorado State University's Veterinary Teaching Hospital. Dr. Burns has extensive experience with transcervical insemination and has been performing TCI in dogs for over 20 years. He also has experience with other species, including Amur tigers. So that's certainly something I can't claim. But without any further delay, I'm going to go ahead and turn this session over to Dr. Burns. So, Greg, just a big heartfelt welcome. I'm glad you're with us this evening, and take it away.
All right. Great, thank you. This is a basic overview of transcervical insemination in the canine. And so talk a little bit about utilizing it in practice. It's not meant to be a complete course in TCI, but this is going to be hopefully an overview for everyone. So I'll start with the goals here. Well, I just have one slide on the history of TCI, which is really interesting to me, having done it for a little over 20 years now. I think that history is important, how we come about learning all these things. And then we'll go over anatomy review in the canine and some unique challenges that may present. And then we'll do talk about equipment used for TCI, scope handling, and then also patient restraint. And then the technique itself we'll talk a little bit about as well. So I have some videos embedded in the slides as well. So we'll go start with our history. Developed in 1988 by Marion Wilson. She's was in New Zealand at the time, and she was using a modified human cystourethroskop. She went later and published this paper, one in the 90s, and then this one in clinical theriogenology was in 2001. And that's when it really kind of took off. And again, she was the first one to really talk about the technique using an endoscopic transcervical insemination in the canine. In 2006, Minitube developed a scope specifically for this with Karl Storrs. And so that really helped us a lot. I learned on that scope on the bottom there. That's that modified human cystourethroskop is what that is on the bottom. And then the one on the top is the Karl Storrs scope that we use today. You can see a big difference in that. We'll talk a little bit about equipment as we go, but I just wanted to show some pictures of those two scopes that have been used. As far as anatomy goes, this is important for us to know, and starting with the vulva and then the vestibule leading to the vestibulovaginal junction. I think it's important to notice a couple things, and one is the length of the vaginal vault in the canine. So that scope we have to go pretty far relative to other species even. So I think it's really important to know that, for instance, when we're palpating them and we're looking for things like strictures and septums, we're just palpating to the vestibulovaginal junction. That doesn't have anything to do with their cervix. And so when we perform the procedure, we have to visualize the cervix and pass the catheter through the cervix. So if you'll notice on the picture on the left where the cervix is located, right in front of that obviously is the body of the uterus. The picture on the right is a gross picture, and the green square is the body of the uterus. So you'll see how far in that scope needs to go, and we need to visualize all the way up to the cervix. Talk about that a little bit as we go through as well. Again, we're looking at the vulva on these gross pictures, and then the vestibule, urethral papilla, urethral orifice, and then that's all at the vestibulovaginal junction. So that's just about as far as we can palpate. We haven't even entered the vaginal vault yet in the canine. If you look at the picture on the lower right, that's the vaginal vault where that starts in front of the vestibulovaginal junction. So that's the caudal part of the vaginal vault. And again, we're not even close to where we need to be to perform the procedure. So we'll move on. I have a couple videos here of the caudal vaginal vault. These are at different stages of the estrous cycle. And so this is important for us too, because we do vaginoscopy as well. And this helps us determine if they're ready or not as far as our ovulation timing goes. This one on the left is in proestrus, and you'll notice a couple things. It's very shiny, it's very pink and even red, and there's lots of discharge. So that's cluing us in that we're into proestrus. These videos were taken with the older scope. That metal shiny part at the bottom is the older scope, the cystourethral that we used to use. This one in the middle is an estrus, and you can see a difference there, how pale that is. It looks kind of dehydrated, and the folds are more prominent in the middle picture. And then the one on the right is in late estrus, and again, there's a difference. So when you're able to perform a lot of these vaginoscopies as part of your transcervical insemination technique, you're able to decide where they are relative to their cycle with the clues that you get in their vaginal vault. Oh, next slide. Once we get to the caudal vaginal vault, then we encounter this thing called dorsal median fold. That's mid-vaginal vault or so. And this dorsal median fold, it's convenient, it's a landmark, but it's also in our way. It does lead to the cervical tubercle, so it leads right to the cervix. And so it's convenient when we see that. We know right where we are in the vaginal vault. It leads to the transverse fold of the tubercle, and then underneath that is a cervical os. And again, I'll have some videos of that as well, I think, later on. The point is that we want to go underneath the dorsal median fold, and we want to approach the cervix, which the cervical os is pointing almost ventrally. And that's where we need to pass our catheter through the cervix into the body of the uterus. Beyond that is the fornix. We can see the fornix easily because it's really different tissue than as the rest of the vaginal vault. It's really smooth, has a different color. So if we pass the cervix and see that tissue, we know that we're in the fornix at that point. So we need to back up and come into the cervix. Again, we'll have some more pictures of that in just a second. So this is the paracervical region. This is the dorsal-median fold right in our way, and it kind of hangs down in the lumen. It's that crescent-shaped tissue here. Hopefully you can see my pointer there, kind of outlining the tissue hanging down in the lumen of the vaginal vault. And again, it's right here on the other. These are still pictures. It's up to our upper left here on this view here. So again, it's good to see that. We know where we are. It's a landmark, but it is in our way. So it's one of the obstacles that we face when we enter the vaginal vault and go up to the cervix. Here's a video, and this is going to show the dorsal median fold. And so that's kind of right in front of us there is the dorsal median fold. So we have to get underneath that in order to advance. That's the catheter. That's showing, kind of pushing some tissue out of the way. The catheter kind of came from the upper left. I'll show that again, or upper right. And again, this is the older scope we used to use. That's an 8 French polypropylene catheter. We'll talk a little bit more about equipment in just a second. And sometimes we can use that as almost a stylet and push that tissue out of our way in order to advance the scope most appropriately through the right fold, most correct fold there. So again, that dorsal median fold is just one of our obstacles in the way. So once we get underneath the dorsal median fold, now we can actually see the cervix. And this is the cervix here. Catheter on the top, and this red area here is the cervix. So this looks more like proestrus. And so how it's kind of red and smooth, less folded. Again, this one on the right looks a little bit more like we're in the right timing with estrus. Again, the catheter is on the top. That's at 8 French polypropylene catheter. Dorsal median fold is on our right. And then the cervix is just peering out there underneath the tissue right here. So that's just the transverse fold of the cervix. So here's some videos as we pass the cervix and get into the fornix, and see how smooth that is and not folded. And so the cervix is here, the fornix, we're just looking past the cervix. It's this tissue right here. The catheter is here, and the fornix is here. And that tissue looks significantly different from that folded, dehydrated, pale tissue that we saw in the vaginal vault. Again, here's fornix again. So we're looking right here past the cervix, and this smooth tissue right here that I'm outlining here, that's the fornix. So once we see that, we know we need to back up, because the cervix is caudal to that, and it just flashed by us here on the left side. This is the newer catheter that we use. This is a 5 French. It's again a polypropylene catheter, but there's graduations on it, so there's marks on it every centimeter, so we know exactly how far we are through the cervix. That's one of the advances with the new equipment, new being as of 06 is when that came to us. So again, just looking at the cervix, at the fornix here, and how smooth that tissue is compared to the vaginal vault, which is very pale and dehydrated. It has lots of folds in it. So obstacles to navigate. As we talked about, the vaginal vault is somewhat long in the canine, right? So we have a ways to go to get to the cervix. It's narrow underneath the dorsal median fold. There's limited space around the paracervical area, and that cervix is pointed ventrally. So the os is facing really straight up to us. So the angle is tricky to get underneath there. I know I'm telling you all the problems right now. We'll talk about how you fix those things, or how you navigate those things. So those are kind of our obstacles to overcome as far as anatomy goes when we're doing a transcervical insemination. So I have just a slide here for questions as far as the anatomy or the history of TCI. We can, if there are any questions.
Yeah, make sure my mic is on. Yep. So, and maybe you're going to get to this, but it seems as I watch the scope pass in, you're pretty comfortable with where you are relative to the anatomy, and I suspect you're making it look easy. So, what is the average sort of learning curve to where people really start to feel comfortable navigating through that anatomy, knowing where they're present, and what are tricks to shortening that learning curve?
Yeah, that's really a good question. So it is a really steep learning curve, and I'll just share my own experience when I started doing this right in 2001. I started doing this, and it all looks good on paper. And I watched one video that Marion Wilson put out. I had the opportunity to talk to her directly about it, and so I thought I was ready to go and put the scope in and had no clue what I was looking at. And I think, so now I can put the scope in and know exactly where I am, unless there's some abnormality present. And that's when things get really tricky, because we do see those. The key, I think, is to this really steep learning curve is practice. And I will talk more about that. But it's really practice and being patient and learning it over that time, and those most appropriate cases that you can use. So, but it happens that way with everybody. Like I said, I think I did these for 2 years for the same cost as just a vaginal insemination, so I could do more and more of them. So it was almost, it was very inexpensive when I started learning them to try to get better at it, but a very steep learning curve. Yeah.
That seems pretty typical of any endoscopic procedure, right? There is that learning curve, and in my world, it's arthroscopy, and I guess I found two things. One is time. Yeah, there's just that something magically happens over time where you combine what you're seeing visually with kind of tactile sense, even if it's only distance. You're just more comfortable where you are. That's one thing, and then the other, it just is like just the breakthroughs that come from guided training. And so when I've watched people learning TCI in your courses, granted, there's still a learning curve. They don't leave those courses necessarily an expert, but it sure seems to me from an outside observation standpoint, that learning curve is shortened. So that's always, as an educator, that's always fun to watch.
For sure.
Yeah. Well, I think we'll just keep rolling. I'll turn it back to you because it sounds like you've got a lot of good information to share in the second half.
Okay. So we'll just go over some of the equipment. And this slide, I have the new equipment that we use here, and new again being around 2006. This telepack is a little bit newer than that. This is in the upper left, and this telepack is I think this is an LED. It's an LED light source. It's just a great little pack. So this pack took the place of all of this equipment. And so this is the original equipment that I used to use in the early 2000s. And there's a giant Sony monitor there. There's a halogen, and then there's a xenon light source there as well. And then the telecam, one of the original store's telecams. And then the other two things are recording instruments, both for still, and then this guy was like a little floppy disk thing. So all of this equipment was just replaced by this, and this is super portable and small and really easy to use. And it's actually more, because I don't have an insufflator on there. I think this one, I don't know if this one insufflates. Anyway, all of that's replaced by this. So there's a light cable. This would be the minimum requirements. And then this is an insufflator here. This is just a hand insufflator that we can use to insufflate the vaginal vault, and then the telecam, and then the scope here on the bottom. So those are some basic requirements. Here are some different pictures of the scopes. Again, the ones on the bottom, the one on the left, the two on the left, actually, those are the old scopes that we used to use. And then again, the cystourethoscope here on the bottom, and then the TCI scope. These two are here on the top. Those are the two we use today. We still have these older scopes. The optics are really nice. They're glass scopes. That's kind of a disadvantage unless you're really into the optics. The glass does provide really good optics, but they're really rigid. This store scope is what they call a semi-rigid scope. The store system also comes, or the mini tube and store system come with this shunt system. And this is from Mini2. This is a shunt system that you can seal the vaginal vault and then subsequently insufflate. There, I still have the old scope on there, but this is where you blow up this little bulb in their vaginal vault, and then you can seal and insufflate. So that's, I think, really helpful for learning because it really takes that dorsal median fold and gets it out of your way. I used this for years when I started using the new scope. I thought it was really neat to insufflate. The visualization is just beautiful. And Yeah, I'll have some comments on that later as well. We don't use it too much currently, at least in our practice. We are very comfortable doing it without insufflating. But I think especially for teaching, it makes that learning curve a little bit easier for teaching. So that's the shunt system. Catheters that we use now are a little bit different. Same material, but they're smaller. We used to use 8 French. I think the biggest one now that I use is 5 French. And I'm really comfortable with the 4 French. They come with a little stylet also. They pass right through the scope and then into the uterine body. You could go up a horn of the uterus a few centimeters if you were so inclined. I don't typically do that. I usually deposit the sample right in the uterine body. They do have a very small dead space in there, so that smaller diameter I think is a little bit better, introduce less air. And then reusing, that's a little bit controversial still. They're meant to be single use. There are individuals who clean these and then re-sterilize these and use them one time. I think that's probably fine. I haven't heard anything, but they are meant to be single use, and they're sterilized in individual packs and meant to be single use. Cleaning the scope can be gas sterilized. I've heard that it does shorten the life a bit of the scope. I have had one for years now and gas sterilized it. It still seems fine. So we do that after routine cleaning with a brush. So that would be steam sterilization in the basket here. Gas sterilization we do here now, and it's fine. It does not decrease the life of the scope at all. The steam will, though, decrease the life of the scope a bit. And then there's the other products that are liquid products that do sterilization and cleaning, disinfection with Sidex like you would other scopes. And then we air dry. We're really vigilant with cleaning of the scope. I would recommend that also. As far as restraint and setup, this is our restraint. This is similar to what Dr. Wilson had back in New Zealand. Actually, that might be hers from New Zealand. The one on the middle one here with the pink colored table. So that's a strap on the side that they can kind of be tethered to the side and stand there on their own. This one here on the right is the one we have here at CSU. So you can see it's really similar. It's got this little door in the front that they can just kind of stand against. It just adds a little bit of support. I typically have the owners stand, and I think I have some pictures at the front. We have a monitor that they can see, and the owners typically like to stand and watch that part. And then we're obviously at the hind end, and I have one assistant just holding from the side. I'll show some pictures of that here in just a second. As far as preparing the scope, the catheter does come within the sheath. I leave it in the sheath until I put it into the scope. So I never touch the catheter with my hands. I do put some lube on the scope. I wear gloves when I do this procedure, and then you can warm up the lube. The scope is pretty small, and if they're in the right stage of their estrus cycle, they stand very nicely. So it's usually not a big surprise when they have the scope. I usually also let them know I'm there. I talk to them and palpate them before we do the procedure, so they kind of know what's going on before we do it. It's kind of nice. We do have this hydraulic table. For years I did them all just kind of on the floor. I would get down on the floor with them, and I've kind of gotten used to sitting on a chair and having them on a table. It's a little bit easier for me, and most of our dogs are used to being on tables. So giant breeds I'll still have on the floor. It's just easier that way because they're giant. I do have my techs hold them from the side, help relax them, and most of the time I like to have the owners present or handlers during the procedure. There are a couple different ways to hold them. There's that rugby ball style hold there on the left. And then sometimes we have them just stand my techs to the side with their arm underneath their abdomen. I don't have them push too much, too firmly on their abdomen, because that will alter our view a little bit, but they really do just like to stand. And see, they get kind of a nervous wag when they stand on the table. A lot of times we'll feed them treats and things like that, but they call it standing heat, right? So they do stand for us to do this procedure when the time is right. Holding the scope, how to hold the scope appropriately. So we balance it comfortably in our hand. This is the appropriate way to hold that scope. I'll show you some slides here of the way not to hold the scope. It's easy to fall into the trap of holding the camera, because it seems like a big handle there hanging off, but that's not the best way to manipulate this scope. You just don't have the best control of it. So holding that scope as demonstrated in that picture is the best way to do it. This is really not the way to do it. Again, it seems intuitive to do it that way, but you just don't have as much control. And the one on the right is close. It's just not as much sensitivity in your palm as your fingertips. So, and I know it sounds maybe a little bit strange if you don't do a lot of endoscopy, but those subtle movements and that control is really, really important. I find when we teach the course, that's the most difficult thing to try to impress upon people, is that the movements are very, very subtle, and you can get a lot of information just by touching and holding the scope appropriately and balanced. So that's kind of just a brief synopsis or overview of equipment. I did put in other questions here just for equipment purposes mostly, and then scope handling too, but mostly for equipment questions that somebody might have for that part.
Yeah, a few questions. So one is, and maybe this is a little bit in both sides of your presentation, but are you ever not able to pass the catheter through the cervix when attempting to perform TCI? And if that happens, does that happen less now than it once did to you, et cetera?
Yeah, for sure. So there are still patients where we can't pass the catheter for whatever reason. We really strive to do this at the appropriate time. So they're in standing estrus, they're in their fertility period. So we can't really blame it on that because we know that it's the right time. Sometimes their anatomy is just not perfect for us to be able to pass that catheter. Right now, we're probably around 1% or a little bit less. So about 1 out of 100 times we can't pass that catheter. As I was learning the procedure, I think we were hovering probably between 10 and 15% of the time until I think 5 or 6 years into the process, then we got down to that 1% or less. And that's where we're at about now. And as it seems strange, but Golden Retrievers is one of those breeds. You wouldn't think that, but Golden Retrievers, and this is, when Dr. Hollinshead came from New Zealand, we were trained completely differently in different countries. We have the same experience with the same breeds. It's amazing, to talk to her and say, oh, those darn Golden Retrievers. So it more often than not, it's that type of situation, around 1%, and oftentimes a Golden Retriever.
And I would guess that's part of your client education up front, is just letting them know, it doesn't happen much, but it does happen. And any tips for what else you tell them?
Yeah, we have lots of tips. I'll go through some techniques with being able to get that catheter through the cervix in the next section. But that's a really good thing to remember, is to explain to the clients up front. And when we're using frozen thawed semen, I usually don't thaw that semen until I visualize the cervix and have at least passed my catheter 2 centimeters through the cervix. So I want to make sure that sample that we're about to thaw, that I'm able to get that catheter through the cervix.
Yep. So it sounds like you've got another section you want to jump into.
Yep.
All right. Perfect.
Yeah.
I'll I'll turn it over to you, and
Good.
we'll maybe have time for a few questions at the end.
Perfect. And I'll go through this part really quick, because again, this is not to really teach how to do TCI just in half an hour, right? Because it doesn't really work that way. But just to give a general overview. So basically here, again, we talked about the obstacles that we have to overcome, right? So we have to go in the vulva, up over the pelvic brim, look at the caudal vaginal folds, navigate that dorsal median fold, roll under the cervical cervical, visualize the cervical os, and then pass that catheter through. So basically that's the process in a nutshell. So look at the angle here that we have to approach the into the vestibule and over the pelvic brim. So we don't go straight in, right? So look, if you look at the angle, and that's a picture of it on the left, and then an illustration there on the right in the Sheltie that we did here at CSU. So I'm introducing that scope into the vestibule at that angle. So that's one of the first tips, right? Then we go over the pelvic brim. So if you'll notice, as we kind of flatten out, right? We become a little bit more horizontal there as we go, as we advance the scope. And then some common position of the cervical os, right? So it's pointing ventrally. So you can just see the tip of it there. This is just a picture. So transverse fold, we're going to have to go underneath this transverse fold of the cervical tubercle. So we really have to go underneath that cervix to appropriately visualize the os. So, oh, this is a video. So here we go. So there's the cervix facing ventrally, and dorsal median fold, again, going to the transverse fold. I just touched it with the catheter, and then we have to go underneath all of that business. Again, there's cervix, transverse fold there. That's not the cervical os, it's underneath there. There it is, right there. So again, with practice, you get it. There's the catheter. That's the old polypropylene catheter. That's an 8 French catheter that's just barely cannulating the cervical os. So really, that's the idea in a nutshell. Okay. So here's a picture. Here's the angle of the cervical os, right? There's a picture of it, and here's a picture of it as well. That's not really the angle of attack that we're going to look at that cervical os, but it'd be nice if we could see it like that every time, but we can't because we're coming from up here at this angle. I think I have a picture. So there's kind of a conflicting angle of the cervical canal and the visualization of it through the scope. So here it's more like this. So that's what we're looking at, and it's pointed down. So I think I have a video here kind of to illustrate that again. And as we go through the folds, kind of using that catheter up, there's the cervix there on our right. And then in just a second, we're going to back out and cannulate the cervix with that 8 French catheter right there. So there it goes. It's just starting to, oh, see how it just came off again? And then just starting to cannulate the cervix. So that's kind of illustrating how easy it is to just kind of go off ventrally. It's not quite working. So that's some of the difficulty. Again, twirling the catheter, you noticed in that last slide, twirling the catheter to try to get it up, and then developing the right angle to get through into that cervical os is the key. So you look, right now she's looking at the cervical os right here. And now she's going to twirl the catheter and increase the angle of the scope to pin it against the cranial part of the scope. So those are the things that you learn in the course. So, okay, limiting factors. Again, most TCIs are pretty straightforward. Every time I say one takes 5 minutes, then I get one that takes 25 minutes. But they are relatively quick. Again, having the owner watch that, or maybe even be at the front end of the patient, I think is helpful because they are amazed every single time. If they've never seen it, they're really amazed. For us doing it for 20 some years, they're like, oh, okay, this is no big deal. So again, rare, I think this is 1 in about 500. I think that may be a little stretch. I think maybe 1 to 200 is probably a little more. So for sure, it's less than 1% for us right now. But again, after I say that, there's a picture of a golden retriever, right? We'll get a run of golden retrievers that are difficult, but it does happen. And some require a little bit more manipulation. So sometimes my tech will, put ventral pressure or push up dorsal pressure on the abdomen to go ahead and change the angle. Sometimes we take them out to stretch out, maybe urinate, that sort of thing, back on the table and then do it. But again, even those are pretty rare these days for us to have to go through those hoops to get it catheterized appropriately. Other problems, sometimes you can fog or have excessive pooling or discharge. Not super common. Fogging for sure. That's where you learn to dab the scope. I think that's probably a common thing with most endoscopy, is to just dab sometimes. We can't flush, or we don't flush typically the end of our scope to clean it. So we take it out, clean it, put it back in if it gets excessive discharge or mucus or anything like that on it. But those techniques of just dabbing it on the mucosal surface to clear it is really easy and useful. Safety considerations, trauma is a consideration. And then pyometra, not really. I get that asked. I get asked that a lot. Oh, we're gonna give them an infection if we do that. So if you think about it, and you think about natural mating and what's involved in natural mating versus us using a sterile scope and catheter, yeah, so much cleaner, right, procedure than natural breeding for sure. And pyometra, at least as we know, the hormonal driven pyometra, that's a hormonal process, right? So there is no greater risk of pyometra versus any other type of mating, including natural. And then one other question that I get, and I thought I would just address this in one of the slides. So versus TCI versus surgical insemination, I still get this quite often. And the misconception is that surgical insemination has a higher success rate, both pregnancy rate and litter size improvement over TCI. And that is just not the case. And there are studies now that support that. Here's 3, I just threw 3 up there, where the evidence now supports that TCI has better or equal pregnancy rates as surgical insemination. So here we don't currently recommend surgical insemination, even using compromised or attenuated semen samples. So for frozen, thawed samples, we do not do surgical insemination. It all ends up in the same place, whether you do surgery or TCI. So there's really not a reason for us to do that because it is not superior as far as pregnancy rates. So, and then just one quick slide on adding it to your practice, adding TCI to your practice. So training, I just want to emphasize that because I started this in the day where I watched a video, right? And it was like not a Betamax, but the other kind of video, right? The tape, VHS tape, right? So that's what I had to watch, right? And then luckily I got to talk to Marion Wilson and she gave me some really practical tips. And then I practiced a lot. But now there are training courses, and I would say you have to have a few things, right? I would have a hands-on training course. I would have the caseload where you would be able to practice this appropriately to get good at it, and then just remember your capital investment. But if you do inseminations and you do artificial insemination, and you do a lot of breeding antherio and repro work in your practice in dogs, I think that you need to have this in your practice. I think this is necessary as having an ultrasound machine now these days for an appropriate repro practice. So with that, I'll take some more questions.
Perfect. Thanks so much, Greg. Great
Yeah.
presentation. A couple questions have come in. One is, would you suggest fasting the bitch before TCI to reduce the bowel content, potentially changing the cervix orientation?
Yeah, that's really a good question too. So I don't typically recommend fasting, but I do, before they come in, I do have them go out and urinate and defecate and really try to get them to walk around a little bit, and do that, because really for us, it's their bladder that gets in the way, and that obstructs our view. And so yeah, I do have them go out and walk around a little bit and make sure that they've urinated, defecated, and ready to go that way, but not fasting.
Okay. You talked a little bit about how your success rate in being able to deposit the sample appropriately has improved over time. You talked about the time that it takes to perform the procedure. But how has that changed over your learning curve? So the time to administer it, maybe one of the complications you mentioned was trauma. Share with us just a little bit about what that learning curve has been like and how some of those things have changed over time.
Yeah, and I think you touched on it just a little bit, because it's funny, because you don't really realize it as you're going through it, right? With your endoscopy, or how your expertise is changing until it's changed, right? And so with me now, because I teach it a lot now, right? We have a resident, and so I'm constantly teaching it. And now she can put a scope in, and I can see right away where she is, where she needs to go, what angle she needs to take. And I think that comes, like you said, in waves, right? So the first part of learning this procedure is that steep learning curve and really introducing the scope into the vaginal vault appropriately, and then visualizing all your landmarks, looking at the cervix, and then being able to just cannulate the cervix. And then all of a sudden, once you get really good at that, then you start to get, oh, well, that doesn't look right. And by not looking right, it might mean, what day of her cycle is she? And then you'll get good at using vaginoscopy as part of your ovulation timing, right? And then you'll get good at looking at all the abnormalities. So whether they have a problem in their vestibulovaginal junction or something that way. So that learning curve is steep, but at each junction, and it's taken years, right? I feel like it probably took me a good 10 years. That sounds crazy, right? But I think it took me a good 10 years to really get comfortable as to where I am now, right? I don't know how much I really, over the last 10 plus years, I've gotten a lot better at it, but I think that first 10 years, I think I improved a lot.
Yeah, I loved one of the points that you made where you talked about the importance of the hands-on training, but as well then practice, practice, practice. And
Yeah.
one of the things I love to point out with all of these hands-on skills that we teach is that, there's this saying, practice makes perfect. And I don't necessarily agree with that. I think practice makes permanent. And so if you learn the skills the right way up front, now you're going to be practicing the skills that you want to have rather than reinforcing some skills that actually are detracting from your effectiveness. And so the old saying, practice makes permanent, is one that people who
Yeah,
I've taught have heard me say a lot. So thank
absolutely.
you
Yeah,
for
it's
sharing that.
perfect practice
Yep.
that makes perfect, right? And developing those skills early on. Yep,
Yep.
I agree.
Yep. Yep. Well, anything else you'd like to share with the audience before we start to bring things to a close?
I don't think so. Just keep in mind our course that we have coming up. And again, those that take that course too, we're always available for support. And so I get emailed now and then, not just on the TCI stuff, right? On difficult cases. That's why we're here, right? We're here for the students. We're here for the CE, and we're here for for all of our partner veterinarians who have questions. So
Yep.
we're always available through email. I like email better. It's better than trying to get to a phone call in the middle of the day. So yeah.
Well, with that prompt, what I'll highlight those courses. I've got that information here. So you and Dr. Fiona Hollinshead are teaching 2 hands-on canine repro training courses here in September. The TCI and canine reproduction course will take place on September 19th and 20th, and the cryopreservation and management of canine semen course will take place the subsequent 2 days, September 21 and 22. So I will say to those who are listening or who watch this recorded, those are both really popular training courses. Additionally, a little insider secret is it's a gorgeous time to visit us here in Colorado. You can't do much better than September. So you won't want to delay in registering for those. So you can check those out. There's some early bird registration discounts, and you can check all that out at www.csuvetse.com. So I do want to thank you, Dr. Burns, for a really informative presentation this evening. We appreciate your willingness to contribute to this CE Elevated webinar series.
Absolutely. Thank you.
I also want to give a big shout out and thanks to Carl Storrs Veterinary Endoscopy, as well as Animal Reproduction Systems, ARS, as our sponsors for this webinar episode. Once again, I'd like to thank all of you for joining us. Next month, we'll learn about the surgical treatment of fractures in dogs and cats. Dr. Ken Brucker will be presenting that particular episode on Wednesday, July 6th. At 7 p.m. New York time. That's 5 p.m. here in the mountains. We'll look forward to seeing you then. And in the meantime, remember that you're more than a learner. You're a whole person. So do take care of yourself, and let's look out for each other. Have a great evening.